Welcome to today's Talks at Pulitzer, the fourth and final segment in our Spring 2020 online Science and Health series. Today we're featuring journalist Amy Maxmen, who will be exploring her reporting on the novel coronavirus, COVID-19, and testing in particular. By the way, while we're waiting for more folks to join us, please let us know on the chat where you're listening in from. I am Ann Peters, the University and Community Outreach Director at the Pulitzer Center. And if you missed any of our prior Science and Health sessions, including last week's segment with author Sonia Shaw, you'll find videos and related blog posts by my colleague Holly Peipenberg at pulitzercenter.org. So we're seeing folks from Philadelphia today, so welcome. Continue letting us know where you're listening in from, and we'll let other people know as well. You'll be hearing from Amy Maxmen, whose work offers readers insights into the initial testing efforts and failures, as well as contact tracing and the rollout of antibody testing, among other topics related to coronavirus. Amy brings to these topics her extensive reporting on infectious disease outbreaks and the social, governmental, and medical responses they garner. She's an award-winning science writer who has received Pulitzer Center support through the years to report on a range of public health issues, including malaria, Ebola, and HIV. Her coverage incorporates the responses to these outbreaks, along with the global and local attempts to address and prevent them. While now a senior reporter at Nature, Amy has had her reporting previously appear in Wired, National Geographic, and the New York Times, among other outlets. Amy brings significant expertise to her work, and as she notes on her own website, before she began her writing career, she earned a PhD from Harvard by spending a lot of time in the ocean and beside a microscope in Honolulu. So we're glad to have her with us today. If you've joined us for earlier talks at Pulitzer, you'll remember that the Pulitzer Center supports journalism around the globe to cover often underreported issues and dig beyond the headlines. And we don't stop with the reporting. We create educational programming to bring these issues to even broader audiences. Like those of you joining today, we see someone from a Croatian who's living in Italy, someone from Oakland, California, and Brussels, so welcome. Last year, we supported more than 180 reporting projects by professional journalists and work with more than 40 reporting fellows from our campus consortium partners. And we have public events like today's session, where we also connect thousands of students and teachers each year during classes, professional development workshops, and more frequently now via online webinars. For our teachers and listening in today and parents of school-age children attempting distance learning, please check out our educational resources and printable lesson plans from our K-12 team on our website. We appreciate your support by joining in with us for today's talk. And remember, we are a nonprofit journalism organization, and so we depend on donor support too. Now, a few housekeeping matters before we move on. Amy will speak for about 25 minutes. We'll then have time for a Q&A. So you'll see a Q&A icon on your screen, and you can begin adding your questions there throughout Amy's remarks. So please go ahead and start that. There is also that chat icon where you can tell us where you're from. And it's also there to be used for more specific technology issues. Note that all attendees are muted, but if you can't hear us at any time, let us know via the chat. We also want to let you know that we're recording today's session to post it online for others who could not join us today, or if you want to come back and listen again. And one final housekeeping matter, please remember to stay online once this session ends to participate in a brief survey to help us better serve your interests. And now, please welcome Amy Maxmen.
Hi, thanks a lot for the introduction. Well, thank you for listening in to my first Zoom presentation. So I'm Amy Maxmen. I have a background in science, but I've been writing for a little bit over 10 years now. And I'm mainly going to talk about COVID today, which is a little bit different for me. So let me get over to my presentation. Give me 1 minute, please. Yeah, great. So basically, most of my reporting to date has really been in various low income and middle income countries because I do a lot of infectious disease reporting. This was for Nature and before that for other outlets. I spent a few months in Sierra Leone during the Ebola outbreak. I've reported on malaria a lot. I've reported on the Ebola outbreak in the Democratic Republic of the Congo last year, Southeast Asia. So I'm used to covering infectious disease outbreaks, which actually do share a lot of similarities to kind of the response that we're seeing now. Is sort of the same basic tenets have to happen. But of course, I have to admit that I really didn't expect to see an outbreak of this extent here in the US. I started covering this, right when we got first word of it in the very beginning of January when WHO started talking about it. But it was more, it was for Nature. And so we have an Asia Bureau. They were really the ones that were covering it. On January 30th, when the World Health Organization sounded their highest alarm, this public health emergency of international concern, that's sort of when, I looked into it, and Dr. Tedros is the Director General of the WHO. His comment at the time was that this the real concern here is what's going to happen in places that don't have a lot of resources. What's going to happen when, people are all sharing one room, when there's not a bathroom at home, when there's not automatic, food in your fridge, not a fridge, and not a health system that has a lot of health workers, maybe no ventilators in the entire country. The real fear was what's going to happen to those countries. And that was my fear too. And I think me and maybe some other people weren't as concerned about the US. For me personally, I was a little bit less concerned because, when I had come back from Sierra Leone during the Ebola outbreak, when I'd come back to the US, what would happen is the CDC would meet you as you leave the airplane. They had like a list of everybody that was coming from West Africa because, of course, we had stopovers on the way. And you'd go into a room, you'd get a phone, you'd get a thermometer. And every single day for the next 21 days, they would call you and you'd have to take your temperature twice a day and give it to them. Anybody that had fevers was, taken very seriously, isolated. And I think they usually ended up having malaria. So it was a really strong public health response, coming from these other places. I was like, what a great public health system we have. Because it was also the state health departments that were a part of that. The other thing is I've been used to going to countries where there is, one PCR machine for diagnostic testing, and it's run by a generator that sometimes goes out. So my other thought was we have these like incredibly powerful labs in the US. So I was kind of under the impression that this idea of sort of diagnosing cases with a test and also a public health response to go with it would be capable here. I think I guess maybe I can share the screen again. So when this occurred to me is I went to visit a friend in Portugal in mid-February and I came back. And at that point when I got back to the US, there was maybe around 300 cases in Italy. And I was really surprised that when I came back into the US, no one asked, cause they didn't ask, have you been in Italy, for example? So that was sort of a surprise. And this was when you were seeing that this was ramping up in Europe. So I was getting a little bit nervous. And then the next weekend, I saw a tweet from, if you're not following him, somebody named Trevor Bedford. He's part of a group called Next Strain. He put out a tweet the very end of February where they looked at the sequence from a virus of one of the earlier cases in Seattle. And it was almost an exact match to the case 6 weeks earlier, meaning that it had been spreading in the community this whole time. And he estimated somewhere between 300 to 1,500 people had been infected within that time. So that sort of, blew me away. And I sent very urgent subject line messages to my editors saying, please send me to Seattle. Like my first gut reaction in an outbreak is that what you see on the ground is so different than what you might hear about from afar. So I wanted to see what's going on in labs that are really looking at what's going on here. I don't usually save newspapers, but I still have the newspaper saved from when I got to Seattle on March 2nd. This is when the second death in the US happened. And Seattle was kind of woken up to this reality that coronavirus had been spreading there for a really long time. So doesn't help that I have too many things open. I'm sorry about this. Where did my PowerPoint go? There it was there, sorry. Give me 1 second. So basically I went to Seattle, and one of the first people I met was this woman named Helen Chu. She's an infectious disease specialist at the University of Washington. And I went to go see her, and she was in the lab that sequenced, she was part of the group that sequenced that second genome of the virus to say this is what's been spreading the whole time. The way they found this case was that her group actually, starting last year, they had been interested in the dynamics of how influenza spreads in a community, because we don't catch everything in our health system. So they had been sending kits to people, asking them to take a swab, send it back to them. And they were looking at influenza virus along with a whole bunch of other viruses to see how these are moving throughout Seattle. So back in February, they really wanted to add coronavirus, this novel coronavirus, to the list of things that they're looking for. They actually even, developed in partnership with a manufacturing company, a test that could actually do this. But they were not allowed to do so because the CDC at this time in February had this policy that the CDC was the only one that was allowed to test for coronavirus. So even though they had the capability to do it, they weren't allowed to use this. Or if they could, they had to do it under a study so that they couldn't report the results back to the people that had the swab. So it put them in a really tricky position, and they pushed and pushed and pushed. And finally, they were allowed to look. And what do you know? They find COVID and they sequence the virus. On that same trip, here's a picture of these swab kits that they send out to houses where somebody can take a swab of their nasal cavity and send it back to the lab. And so now they are using this for COVID. They've expanded that. The same trip, I also went to another lab at the University of Washington, working with Fred Hutchinson Center. And they too, this was a huge diagnostics lab. Now they serve all of the, not all of them, but a lot of hospitals in the whole region. And they have enormous testing capacity. So, many, many, many times more than the public health department. And they had actually, the WHO had listed protocol for how to test on their website. So they had even looked into this. They were ready to do the test, and yet they weren't allowed to because only CDC could. And if they wanted to register a new test, there's a very long regulatory pathway to get it approved from the Food and Drug Administration. So they weren't allowed to use this. Finally, February 29th, the FDA said it was okay to, if you had the right clinical license, it was okay to start testing. Of course, you have to still get a use authorization from them. So they went ahead and did this. And so they were off and running. When I was there in the very beginning of March, I went into the lab and they had people that had been there all night. So they were really working around the clock. They were doing, researchers work hard. I used to be in academia. I have a PhD, and I can tell you, these are people who on Christmas would be outraged if the door was locked. They're going to work very hard towards this. So I was sort of there when they were just off and running and saying, this is a problem. We're going to get on top of this by seeing how bad the problem is. So, I went home, and soon after I went back to California, we put down shelter in place orders, which was good because I kind of left Seattle with this new fear of having talked to the head experts in the area saying, this isn't contained, this is really bad. So I suddenly myself was, okay, I'm not going to do what I normally do, which is walk around. I'm going to stay home and report this. But then I'm paying attention to some things. So when I had reported on Ebola in the past, sort of the cornerstone thing that you have to watch is it's not just testing people. That's the first thing that has to happen. That's the most basic thing. But besides that, there's something called contact tracing, where what you want to do is, the idea is to precisely stop a chain of transmission. So as soon as person A tests positive, if person B and C were around those people or close with them, what you want to do is reach them as soon as possible so that B and C don't give it to D and E. And you want to make sure they're isolated from other people or quarantined if you haven't yet tested them, and get them a test, as soon as you're able, or at least when they show symptoms, so that you really isolate them. It's not to say that social distancing doesn't matter. That is a part of it. But, I'm shelter in place in California. I still go to the grocery store. Other people have families they're seeing, or they have, people they're dating, or they have friends they're seeing. So this is sort of the number one thing to do in outbreaks. And what I was getting worried about is this contact tracing that I had just seen happen in the Democratic Republic of Congo. Huge, complicated, hard, and always imperfect effort. It wasn't even happening here. In fact, Seattle, a lot of counties around me were saying they're just not going to be doing contact tracing. So this made me nervous. I even talked to people from the WHO and public health experts just to make, I'm sorry, that's my chihuahua. Stop it. So I even talked to public health experts to see, am I going crazy? Is this not a thing? And they are saying it's definitely something we should be doing. And I don't know why it's not happening. And as I was looking into this, sure enough, on Twitter, I saw that somebody tweeted, a scientist tweeted, a geneticist tweeted, guess what? I'm in the ICU and I have coronavirus. It turned out that a week earlier, in early March, he had been in a small meeting with scientists from across the US, about 20 people, where they were deciding on what genetics grants should go forward. And these people in the room with him didn't find out that he was positive for an entire week after that meeting. And he was, had all the symptoms of COVID just a few days later, and yet they weren't even notified. And, kind of what this looked like is, for example, I talked to one of the researchers there, one of the geneticists in that meeting, just 24 hours before the tweet went up, she had had dinner with her parents who are in their 80s who have underlying health conditions. And a few of the people in that meeting were already feeling sick. They were trying to get tests. A lot of them couldn't get tests. And this sort of shows you why this is a really big deal. So I wrote this piece, and it's about testing, but it's also about what happens next. Kind of at the same time throughout March, this is all after I got back from Seattle. The same time, the biggest kind of these big money labs, like labs that are really at the cutting edge here in the US. For example, I'm, down the street from UC Berkeley. Across the way, there's University of California, San Francisco that works with the Chan Zuckerberg initiative. There's the Broad Institute of Harvard, MIT, Boston University. There's labs that have a lot of capacity, and they did want to test. They know that they have the equipment that can do this. They have the expertise. They're really the top scientists. So they were working really, really hard to ramp up testing. So for example, this is down the street from me, at UC Berkeley. This is sort of the lab that is set up to do genomic engineering, way more complicated things than searching. These PCR-based tests basically looks for the virus, sequences in the virus, and that's how it sees it. So they completely pivoted all of their efforts, all of the money that they have, they threw into getting new equipment, and they think they got something like 800 people volunteered within 24 hours. Huge efforts to pivot the entire lab into coronavirus testing facilities. So what I did is I started talking to the researchers who were doing this, because I'm curious, we do have big commercial diagnostic labs like LabCorp and Quest, but we know that they're backed up. We know that lab results have taken many days to return in some places. And, when I was writing this story, there was reports of like 60,000, backlog of 60,000 tests just in California alone. So they're just not able to handle it all. So these big academic labs really do matter, but some of them are already connected with hospitals, but some are not. So for example, Berkeley was not. In order to get the license from the FDA is very hard. It's called a CLIA license. So people are getting creative. So what they did is they ended up actually partnering with the Student Health Center, which had a CLIA license. And that alone, to file for an extension of that license, that took work. So they went through all of this paperwork. In the meantime, they're hiring new people, they're training new people. Also, there's supply chain issues. So some supplies are short. So they kind of are, instead of just picking this one protocol for testing, they're finding new protocols, new pieces of equipment that maybe aren't going to have the same supply chain issues. So they're going through all of this. They're working around the clock. They finally get it all up and running. This is Berkeley, but also, I've talked to almost a dozen other labs in similar situations. And then they hit this other roadblock. So here's just one quote from a story I wrote about how a lot of these tests are going unused. I mean, I was talking to labs that have capacity to, easily do 1,000 or 2,000 tests in a day, but they weren't even at half their capacity. What happened is a lot of researchers found that even once they spin this up, so Fyodor Urnov, he's one of the scientists at this IGI center at Berkeley, this genomics center, he says, I show up in a magic ship with 20,000 free kits and CLIA and everything, and the major hospitals say, go away, we can't interface with you. So this was another challenge that they had not expected. And this is all happening within the month of March. So this challenge was a lot of hospitals were then turning away this ability to test, even though the diagnostic centers they traditionally go to couldn't get to the test for days. There was a few different reasons I heard. One reason I heard was that the electronic health records that hospitals use aren't the same, don't interface with the software that these new academic labs are using. Remember, they're not used to working with hospitals. So because of that, they wouldn't work with them. Other reasons were I heard that there was existing contracts. So if they were contracted to work with, say, LabCorp as an example, they couldn't change that contract. And this would even be if LabCorp wasn't able to get to the test for a while. And I heard this, and I heard some other stories. I did reach out to Sutter Health, which is one of the big lab networks around me. And they said they were going to ramp up their own internal diagnostic testing facility that should be ready in a few weeks. So there's sort of a lot of issues that maybe and I think a lot of researchers also hadn't counted on. Yes, we have the abilities, but the system for how this all fits together is extremely arduous and very rigid. So that's actually a very important holdup, and it's something that a federal response could really help with, and at least a state response, something that really coordinated all these different labs, which is not a small effort, but it's an extremely important one. And of course, I'm not the only one who's been reporting on testing. The New York Times has had a lot of great pieces. And just to give you a sense of where the US stood and stands, is you want to have way more people tested than who are positive. That's the goal. That's what should be happening, because most people are going to be negative. So you get a sense of if you're really finding everyone, if you're testing lots of people. And so if you just compare here, even like look at South Korea on one hand and look at the US on the other, and you can see it's woefully inadequate. And I think that still actually continues today, because of course cases have gone up, so the need for tests goes up. So it's difficult. And then the contacts go way, way up above that. And we might have heard a lot at this point about, South Korea had a really strong, super strong response, lots and lots of testing, incredible contact tracing. So did Singapore. There's a great YouTube video from Singapore of somebody on a medical team explaining how they have 24 hours to figure out everybody's possible contacts the minute they're positive. And they'll look at people's receipts that they might have carried to see, okay, were they in these stores? And they contact people really rapidly. The idea is find the contacts and then they quarantine the contacts. Taiwan also did an incredible job, as did Hong Kong. And when they quarantine people, they also provide food for them. They provide financial support if they need it, because if you can't go into work, you need to have some sort of support. And then once there's positive cases, they isolated them very rapidly. So this is a major part of the public health response that we are still sort of hurting for. So we know a lot about I think Asia has been talked about a lot, and rightly so, because they have honestly done some very impressive public health responses. Because I'm also interested in other places, I was interested in what was happening in low resource settings, places that are low and lower middle income countries. So I did another story where I looked into this, and it turned out that a lot of countries that don't have the hospital capacity we have, maybe weren't under any illusions, no, they don't have enough health workers, no, they don't have lab capacity, no, they don't have any ventilators or very few ventilators, and that this will be a devastating thing for them. There's a lot of countries who took really, really fast and strong and strict steps right away. So just to give a couple of snapshots, here's a picture from El Salvador. Before they had any cases, they shut their borders. There's still deportations going on, but they did shut their borders as much as they could. And they imposed really strict quarantines and very strict curfews. So here's two young men. They were riding around town on their motorcycles. They didn't have permission. If you want to leave home, you have to have it has to be one person, and you're going to, say, the grocery store just for essential duties. You're not going on a run or anything like that. I heard similar stories, maybe not as strict like this, but for Peru, for example, they also shut their borders very quickly. And on top of that, they also started building these isolation centers. So here's one picture. This was before they had any cases whatsoever. They were building up to get ready. So this is a story. If you want to read more, I can link to it later, but I'll send it to the Pulitzer Center, and also I can tweet it out if it's helpful. But so this is just going through a few other places. So in Nigeria, on February 3rd, remember, this was back when the US was not allowing anybody else to get into testing. February 3rd, they got tests from the WHO that were created from German scientists. They got these tests and they started expanding their lab capacity as much as they could. They were really ramping up. By the time they had 2 deaths, which is when I wrote the story, they had closed their borders. They had also closed the borders between states. They had shut down a lot of domestic travel, both by road and by air, and they were closing businesses. In Peru, like I said, they had very strict lockdowns and curfews. And in fact, I should say they broadcast this. So you could even see in press briefings from the government, they would say how many people they had. At first, they were, bringing people to the police station and, fining them or giving them a record. Then they stopped bringing people in because that's a risk too. But they were actually saying, and it was some you can see in the story, but it was, in the thousands of the number of people they had arrested for, say, taking a jog. So they were really doing this strictly. Kenya's known for imposing a very strict curfew with violence, which is not good. And we can discuss human rights issues here even, but the idea is that they really wanted to contain this before it got out of hand. And I think quickly actually it turned out that Peru was also shipping, and they wanted to get 1 million of these antibody tests, which we've heard about so much. So you might have there's a lot of news on antibody tests lately. So there's, just to kind of outline what they are. First of all, the antibody response. So PCR tests I've been talking about so far, that's what I've been focusing on. That test that test looks for a genetic sequence within the coronavirus itself. So it's saying the coronavirus is in you. Antibody tests look for the immune response that we generate in response to being infected by the coronavirus. And there's different waves of an antibody response as well. And I should say it's part of the immune response to fight viruses. So the first wave of antibodies, they can be called IgM or IgG. Those come on, we don't know exactly with this disease, there's so many unknowns, but anywhere between, let's say, 3 to 11 days is what I've heard for this quick antibody response. Later, as you're more in the recovery phase, or maybe you didn't even get sick, we know there's asymptomatic, there's a second wave of an antibody response, IgG. And that later wave often is some sort of, think of it like a memory. So it remembers that you were infected by this virus, so that now in the future, if you're infected by that same virus, you're going to get an immune response right away, a strong immune response that will keep you getting it again. Now that does not happen for every disease. This is the trick. We're still kind of figuring it out, but it does happen for a lot of viruses. So that's why you've kind of heard different things about antibody tests. To make matters more complicated, there's fast ones. That's in the picture here. These are like, you put a pinprick of blood on one section of this and you get a band for, you know, one of these antibodies I've just talked about. And the band says presence or absence. And there's other tests that require more complicated laboratory equipment that can look at the level of certain antibodies, and that tells you a little bit more about them. Those are a little bit more thorough. You know, and I think this has been all over the news, and it can be a little bit complicated, and that's because there's a lot of unknowns right now. One of the things is there's tons of these, there's, you know, more than 70 of these rapid tests, this picture with the little sticks. There's tons of these tests coming out. They haven't been adequately vetted. Some have. So I feel like it's not to say these are going to be bad, but the idea of just ordering something, you know, anything you find, just ordering it and suddenly going out and testing and feeling like you're learning something, that's a bad idea. They do have to be vetted pretty carefully by labs. But I talk to scientists that believe in them. So this is not to say they're useless. So there's two different ways that the scientists I've talked to are thinking about them. For example, I talked to a researcher in Virginia, and he's got a rapid antibody test. This is the stick that gives a result in 10 to 15 minutes. And he's offering them to people who have some symptoms or who think that there's a good chance they could be infected. For example, health workers. Right now, nurses and doctors, most places in the US cannot get a PCR test unless they have symptoms. There's some exceptions to that, like if they're connected to a university lab that's already testing. Now, the problem with the symptoms thing is we know there's asymptomatic carriers, and these nurses and doctors are often really worried. What if I'm infected? Because we know that there's a high rate of COVID. What if I'm infected and then I go and treat somebody who has diabetes or cancer? They're really, really afraid of infecting other people. So that's a true fear. So this person in Virginia was getting a lot of people asking for these tests. So he would test them and then couch the results very carefully. If they had this acute response, the IgM or the IgM response, that's a sign they could have an acute infection. So he had a doctor come in. She had this IgG antibody band show up. He tested her again because, you know, there's an accuracy question, still positive. She was supposed to go into work that day. She decided against the rules of the hospital to not go in. He also did a nasal swab for her and sent it out to a lab for the PCR test. But that was going to take at least a couple of days to come back. So in the meantime, she decided to just go ahead and quarantine. And it turned out she was actually positive. So an argument there is, when you don't have a PCR test, is this going to be a useful proxy? Now, remember, the danger is that you don't mount an antibody response for a few days, so you could get a negative and yet still be infected. And then this protective one, IgG. So a lot of places are betting big on this. In the very beginning of this talk, I talked about the University of Washington, and this was the lab that wanted to ramp up testing in February. Well, they've quietly ramped up their antibody testing as well. So now they have the capacity to test 15,000 antibody tests per day. And they're sort of betting big that this will play large later in the outbreak. But we have to answer some questions first. The questions are, okay, if you have the IgG antibodies, are these protective? And the way that scientists are looking at this is in two ways. One, in places connected with hospitals, like at the University of Washington, like in this photo in Detroit. One is if they're testing a lot of health workers who are at high risk of getting COVID. What they're going to be able to do is see if these health workers have positive IgG, and in the next month or so, how many of the people with IgG end up getting COVID versus how many who don't. So that will give you some sense that maybe they are protected. The other thing that people are doing is they are then taking the blood from people who have IgG and putting it in a culture. So you get a mix, you put in sort of a test tube, you've got your blood that has the IgG, and then you put in some of this coronavirus, and then you put in human cells. And now if those cells don't get infected, that tells you that the antibodies are probably clogging up the virus so that it can't get into cells. So that shows it also is protective. This is an unknown right now, so it would be foolish to say I have IgG and therefore I'm fine. We don't know that for sure, but we are going to get that data soon. I think, I've gone a little bit over what I wanted to do, so I'll stop there, but I would love to talk about anything.
Great. Thanks so much, Amy. There's a lot I know that you can dig in further on this. One question to start off, you were talking about the University of Washington. You're talking about, for example, the example you gave on the healthcare worker. Are you seeing a particular state or locality that is making it work well with testing in the US? You gave us the examples with South Korea, for example, doing really well, and some other places. But in the US, is there a place that, from your reporting, that seems to be doing better on the testing, on the initial testing, and then on the antibody testing, or one versus the other?
It's a really tough question. I mean, people are doing well. I guess I would keep looking at Seattle because they have a few things in their favor. They have very good infectious disease people. They have a very good public health specialist, and they've been working with the state and city health department, state and county health department for a long time. So they're really tightly integrated there. They're not doing much contact tracing as far as I know. So they're not strong on that aspect, but they are very strong as far as testing and trying to get ahead of it that way. And I think there are areas, it is very local because, I know at Stanford, for example, they are screening health workers pretty regularly because they have in-house testing capability there. So there's places that are doing it well. The tricky thing is, this is outbreaks are local is sort of what how the saying goes. So you can have, one part of a city doing really well and another part doing really poorly, and people travel between those two places. And we know already there's disparities. So, you could have San Francisco might be great, but I'm always curious about how's Oakland doing, just across the bay. I talked to a scientist who's in Marin, which is a wealthy area of California, and he's got great testing capability there. He also works in Vallejo, and there he has to wait days to get a test result. So it's quite patchy.
And California is one good example. From the state level, then, what have you seen as far as the state response trying to alleviate these disparities? Or that's still in the works, do you think?
It's still in the works for sure. I think, California did really well and they enacted their stay-at-home measures I think they might have been first in the nation, I'm not positive, but pretty rapidly and pretty, with a strong response. I know I've heard in my area, the Bay Area, that we flattened the curve, which means, and I've talked to ER docs who say they're not getting the kind of flooding we might see in New York. Of course, it's way less dense than in New York, and people don't use public transportation hardly, so that's a big difference. But there's still no, as far as testing and contact tracing, that's really not there right now.
Mm-hmm. We have a couple of questions related on antibody testing.
Yeah.
One is in terms of, do you think this idea of if antibody testing is to help us guide reopening plans, will this, though, kind of sow some confusion? And then, so that's part one. Part two, from Alexia is, so if you, I guess if you have a strong immune response, does that mean you won't get it again?
Yeah.
So again, those two questions there.
So we're in a phase right now where there's the main thing we need to know is, are you protected when you have this IgG response? And I realize I should have showed, there's a graph, if you can picture it. The graph would be like, infection, and then there's like a slow buildup of this one kind of antibody. And now there's a second line that starts here, and there's that antibody response. So remember, there's two waves. So the second wave, the IgG wave, we need to know right now, we don't know if you're protected. The bottom line is we don't know. So I was interested in the the way there are a lot of researchers though who say this very well could be true, and they're counting on it. So they have put a lot of money into ramping up their ability to test for this. So they're really hoping that's true. And they could be wrong though. That's the point, is they could be wrong. So they need to find out, and that's why they're doing those two studies. One, testing people at high risk of getting COVID, nurses and doctors, and then we're going to see in the 2 months to come, are they infected more often or less often? If we see that they don't get infected again, well, now we know. And then also those kind of laboratory tests to see when you mix up blood from people with those antibodies, with the virus and with the cells, does it stop infection? So that's the other way to test for it. It's called neutralizing. So are they neutralizing antibodies? Okay, so I think the other question is, will they help us open the economy? So once we answer those questions, there's a very good chance they could be really effective. There's two ways they could be effective. One, if people have these antibodies, you can say, you don't want to force anyone to go back to work or something like that, but you could say, listen, you're probably protected. If you want to go back to your job, that's okay. That's one idea, that it could be used for that. It could also be used, you can imagine if people want to travel. This idea of immunity passports, which is definitely bad right now because we don't know if that's true, and you don't want to pretend it's true when we don't know. But it could be useful in that way if it turns out to be true. Then there's the early response, like I was talking about, this kind of first wave of antibodies. That could also be useful, one could imagine, if there's essential workers. Just in as much as saying, if we're not able to do PCR, this test for the virus, what if you could periodically screen everyone? Say there's a construction crew that all works together. What if you screen them every week or something? If you don't have the PCR, if you screen with this, at least to get a sense that some people might have an acute infection and therefore they shouldn't come to work and that they should quarantine. Of course, they should be quarantined and not fired from their job. But that would be another way that it could be useful. I think as we open the economy, you do want to have some more data on who's infected or who's protected.
Mm-hmm. And one other population that one question from Gay has asked is, you were talking about the healthcare workers. What about immunocompromised individuals who do become infected but recover? Have you heard of any testing related to that? How accurate would that testing be?
There wouldn't be, there shouldn't be any difference in the test because both of the tests, so the PCR test is looking for the coronavirus itself. This is SARS-CoV-2, SARS coronavirus 2. So it's looking for that specific one. And the antibodies that we're searching for are specifically for this coronavirus and not antibodies against any other. There's antibodies, of course, against many viruses, but the ones that are good are mainly going to look just for that specific virus. And let me know if that's not the answer you wanted, though. I'm not sure if I understood.
Okay, well, we can ask if that was not clear to you, let us know in the Q&A if you have another follow-up question.
Yeah,
we have another question from Anita, who wants to know, why do you think countries outside of Europe and North America took so long to grasp the risk compared to the examples you mentioned in Latin America, for example? And I'm not sure if that doesn't take into account the Asia examples you gave, but the comparison between Europe, North America versus what you were talking about in Latin America, where it was more of a concern that you had for individual countries and locales that may have not had as much in terms of hospital beds and so forth to take care of.
So it's not that they didn't have concerns. So a lot of the places that I was reporting on, they have no resources. I think the World Bank collects data on number of nurses per 10,000 or 100,000 people. And a lot of these countries are very low there. So they have a low number of health workers to serve the population. They have very low lab capacity. So like I said, the problems in the US I wasn't expecting is we have tons of lab capacity. We have electricity everywhere. The places I'm talking about, Peru is a middle income country, yet their lab capacity to test for this is really concentrated in the capital, and it's not outside in the rural areas. So it's not that they didn't expect, they actually have always been worried about this. So it's a great question. And in all of my reporting, you know, when I went to DRC in the Congo, the thing I went with the Director General of the World Health Organization, and the thing he kept saying is like, he's really hoping to bring up the health capacity in all of these countries, because this is a standing risk, and these countries know that, and they're really tired of, you know, it takes an emergency to have everybody say, oh look, they have nothing, but they're like, we need to just bring this all up. It's a huge risk for the entire world. So that gets back to kind of a long-standing need to improve healthcare.
Mm-hmm. One question, you had mentioned some of your early work, you were interested, or you had seen this report from this geneticist, I think on Twitter.
Yeah.
Could you talk a little bit about how you utilize Twitter, whether to push out your reporting or to see these trends or sources that you might be able then to follow up, especially maybe we could pull it down into how you've been using it most recently with COVID-19.
Yeah, I would say it's definitely changed. You know, for some of the other diseases I've reported on, you know, there's not as many people on Twitter. So what's different about this outbreak is scientists are right up there on Twitter. I mean, the one I wrote about how all of those scientists were infected in a group, I saw that he was infected on Twitter. When they saw it, it's a weird world right now. And a lot of scientists are putting out, you know, what they're doing. They're being really open too and putting out their results on Twitter. So it's a little bit maddening. And I don't think you want to waste, I mean, I put too much time into Twitter. So that's the downside. But the upside is it is a neat thing to learn things in real time, you know, like, yeah, to just sort of, so with Trevor Bedford, with this next strain, that's a really interesting account to follow, because he happens to do a great job at sort of explaining the science of like, you know, one of their recent ones is they looked at sequences from New York, virus sequences, and they realized a lot of these, of the early ones, the initial cases were coming from Europe. So we can see that, you know, people traveling from Europe brought a lot of the cases into New York. So you can see these really neat connections. So that's all on Twitter. What do? I try and follow the right people. And when I find something, the key is to then get off of Twitter and do a little bit, you know, have they published something, see if other people have written about it yet, and then maybe I can reach out to them and talk to them about it. Of course, they're all super busy, so my conversations often end up being at night or on the weekends or things like that. But yeah, I think that's pretty much how. And of course, I put my own work on Twitter because that's the way the world works now. This is how people see it, is through social media.
Mm-hmm. And to get the accurate representation, as you were saying, so many things are flying around.
Yeah.
To put that information out there.
Yeah.
Well, we could probably talk for longer, but we have to wrap up. So I really want to thank you, Amy, and thanks to our audience today. There might be a couple of questions that we can also follow up with when we post the recording of the video and the blog post. And want to thank especially Holly Peipenberg, our producer for today. So we just gonna hope that our audience will stay with us for a few more minutes. Just to remind you that we'll have a brief survey once we officially end our session today. And we also want to let you know of a few upcoming online events. Please join us and our Rainforest Journalism Fund for a webinar introducing methods for investigative environmental reporting. The webinar is called Investigating Environmental Crime, the Data, the People, the Money. It is a free 1-hour event. And while it's designed for journalists, the registration is open to the public. Please note to check your time zones on this one, though. The event begins at 9 a.m. Jakarta time on May 5, but for those of you in the US, that would mean during the evening before on May 4th. And then please also check online at our events page as we're preparing for more sessions in May and June, including a deep dive data journalism workshop. And we want to thank you for joining us today, and to remind you that next week is Giving Tuesday. It's a new global day of giving and unity taking place on May 5th. And so please take some time to visit thepulitzercenter.org to learn more about our support of journalism and especially science and public health reporting during this critical time in meeting the COVID-19 moment. Thank you again, and thank you, Amy, and have a good afternoon.
Thanks.
Thank you.